Hello everyone, my name is Sreelakshmi Sivakumar. I'm one of the clinical fellows currently working at Queen's Hospital, Romford, London. So I'll be presenting a case report on mental health and diabetes management in an acute setting. So this is supposed to be, this is meant to create an awareness regarding, as clinicians, are we doing the right thing for our patients? So the, the prevalence of psychotic illness and diabetes is 2 to 3% more than that in general population, and this was recognized almost a century ago. Diabetic, more than diabetic complications, this increases the risk of cardiovascular diseases as well. So patients on what we see usually is patients on antipsychotic medications developing type 2 diabetes mellitus. But this case report is more towards a holistic approach towards create a holistic approach towards treating mental health and diabetes together. So as a clinical fellow working in an acute medical setting, we see a lot of patients presented with complications like hypoglycemia, DKA, and HHS. And it becomes a vicious cycle when they have comorbid psychotic illness as well. So my first patient was a 40-year-old lady who had the background of type 1 diabetes mellitus, diagnosed at 20 years of age, and she was on insulin. She has been living in a mental health hospital since May 2020 due to psychotic depression. She was presented to us with seizures and a BM of 2. So when we took the history, we came to know that she was given insulin even though she wasn't eating and drinking. So due to her poor compliance to insulin as well as her antipsychotic medications, she ended up like this to our acute medical setting. And we started her treatment, but still she declined her food and medications. Later, due to all these reasons, she developed DK and orthostatic hypertension. As any clinician, we started her on sliding scale and IV fluids, but still she was non-compliant. So she repeatedly kept removing her cannulas. She tried to move around without any support. She denied any DM checks because of her mental health issues. She was repeatedly saying that people are conspiring against me and I just want to leave the hospital. So what we did was, as a junior doctor, myself and my consultant, we sat with her and reassured, and we gave her more attention and care so that she will take her medications. Then she started eating and drinking, and the nurse, in the meantime, the senior nursing team decided to move her to another long-term ward once she got settled. But my consultant insisted to keep her in the same ward to prevent the borderline decay to change into a full-blown decay and to avoid any change in environment which can stimulate a psychotic episode. And there are chances of a suicide attempt in a psychotic patient if she is moved from a ground floor to an upstairs ward. Then a psychiatric review was done for her. A consultant psychiatrist came to see her. He talked to her, tailored her medications, and a daily review was scheduled. And she was assigned with the same nursing staff. So these were the things that we did to make sure that she's well from both sides. So the same nursing staff was assigned because she wanted to feel comfortable with whoever she's getting the medications from. We also liaise with the psychiatrist from the mental health hospital in a daily basis, and a proper individualized care plan was made when she got discharged, which had proper instructions regarding her long-acting insulin, her short-acting insulin, the time of administration, and everything. And she had a strained relationship with her family members, especially her sister. So we addressed their concerns as well. We updated her sister with the details of her treatment, and she was sent to the mental health asylum, and we are following her regularly now. So coming to my second patient, he was a 31-year-old man. He's also a known type 1 diabetes mellitus on insulin with a background of paranoid schizophrenia on aripiprazole. And he was admitted to us with severe DKA and immediately sent to HDU because he had life-threatening DKA. So On taking history, we came to know that his decay was precipitated by his poor compliance associated with his mental health issues. So he wasn't taking any of his insulin because of the fear of hypos, and he wasn't getting any adequate support from his general practitioner as well. So while he was in HDU, he was reviewed by the diabetes specialist every day, and he got better, and he was stepped down to the ward. And later on, in the ward, he was reviewed by the diabetes specialist every day. A diabetes nurse specialist review was done. Then he was reviewed by a psychiatric consultant. So it was like a hand-in-hand work done by both teams so that the patient was treated in a good manner. And later on, he was followed up in the community regarding diabetes as well as mental health point of view. We also talked to his mother, who is his main caretaker, and her concerns were also addressed. But unfortunately, he came in with similar episode, with a similar history to the hospital. So coming to the discussion, uh, the topic of mental health and diabetes is a challenging task. So the first priority should always be given to treating the psychosis, even though the medications for psychosis can cause can impair the glycemic control. So without adequate control of the diabetes, without adequate control of the psychotic symptoms, the entire medical management of diabetes can be futile. So in a patient with psychotic symptoms, especially if the patient is having any positive symptoms of schizophrenia, patient can have, if the patient can, it will be hard to make them engage in the diabetes treatment. If the patient is having negative symptoms, it will be difficult for us to motivate them to take the treatment. And if the patient is having manic symptoms, they will be very overconfident to understand the side effects or the complications of poor diabetic control. So both the outcomes are worsened from the diabetic point of view and the psychiatric point of view. And there is a psychological burden if the patients are started on insulin as well, because they are pushed to do needles and injections more. So the treatment always should go hand in hand with psychiatry and diabetes specialists. So the real challenges are, we have to monitor their own blood glucose concentration, and they have to calculate their insulin doses and self-inject. And there is a difficulty in attending outpatient clinics. They most of the time they fail to attend the outpatient clinic. And when they're using insulin, the rate of depression is more in such patients because of the treatment demands. Also, it's very hard for them to put in a diet control. Also, a sedentary lifestyle, lack of poor quality sleep, all these attributes to poor glycemic control, which in turn lead to cardiovascular risk in turn. So what we can do as medical professionals? Always it should be a collaboration between psychiatry and diabetology teams, as I said so far. The priority should be given to stabilizing the mental health, and the patient should be compliant of the treatment from both sides. Um, a single consultant can be assigned to one patient, and in case of any complication, the patient can inform that single consultant so that the treatment can be tailored. Also, the patient also needs support from family and friends and the community mental health team regarding this issue. Now coming to the education, first of all, it's patient education. So patient should be, a specialized nursing education should be given to patients regarding own blood glucose monitoring and self-injection of insulin. Coming to the family support, um, family should be supported to consult with the specialist who is involved in diabetes management and psychiatric illness, as well as they should be encouraged to take the patient to outpatient clinics so that the patient have regular follow-ups. Coming to the most important thing, that is the nursing support. A patient in an acute medical setting as I said earlier, we made sure that the patient is seen only by the same nurses so that he or she feels comfortable with the treatment. And also another thing is diabetes nurse specialist who plays a major role in leading the treatment provided to a patient who has been diagnosed with severe mental illness with their diabetic care. Coming to the pharmacology, which is also important in treating diabetes and psychosis, um, the proper mechanism, the whole mechanism is unclear, but the proposed mechanism so far is of impaired glucose tolerance, which is a side effect of most antipsychotics. And mostly it is caused by obesity caused by the antipsychotic medications, especially like clozapine and olanzapine. And it also causes direct insulin resistance. That also causes impaired glucose tolerance. It has a mechanism via leptins causing increased food intake, leading to obesity, and so on. So as clinicians, what we can do is we can do the basic diabetic investigations before starting the patient on antipsychotics. And then later on, we can start them on 3 to 4 month investigations and later on annual investigations. And technology can also be used, like the new technology like Abbott's Freestyle Libre, which is free of needles, which helps the psychiatric patients more because patients who are afraid of taking needle stick can use this technique, and it can be kept for almost 14 days so that the diabetes specialist can tailor the regime of insulin the patient should take. And a more awareness should be created between the physician and other healthcare professionals regarding this. And it should come from a primary and secondary care level. And it should be a multidisciplinary approach, combining the nurses as well. So the take-home message that I want to give is that it's a coordination of care between all of us, because mental health illness and diabetes is highly prevalent in the community. As I said earlier, it's 2 to 3 times more than in general population. And the awareness against this can avoid a lot of comorbidities and complications. It is challenging, but recognizable and treatable, and it can help our patients to live a long and healthy life. And these are the references I used for my presentation. And here's my team. And I represent Barkinghaven and Redbridge University Hospitals. Thank you.